So good morning, everyone, and thank you for joining us. My name is Steph Kershaw. I'm a research fellow at the Matilda Centre for Research in Mental Health and Substance Use, located at the University of Sydney, and I also coordinate the Cracks in the Ice program of work. And it's my great pleasure to welcome you to today's webinar. Before we begin, I'd just like to acknowledge the traditional custodians of the land and recognise their continuing connection to land, water and culture. I'm currently on the land of the Gadigal people of the Eora Nation, and I pay my respects to their elders past and present. I also further acknowledge the traditional owners of the land upon which you are joining today and pay my respects to their elders past and present. So today's presentation is one in a series of webinars which is focused around methamphetamine, and it's running as part of the Australian Government Department of Health and Aged Care funded project Cracks in the Ice. So before I introduce today's speaker, I just wanted to let you know that as participants, you are in listen only mode, and that means that we can't see or hear you. However, you will notice that you have a Q&A button on your dashboard, and this is where you can type in questions that you have during the webinar and send them to us. We'll also be having a Q&A section at the end of the webinar. We will be recording today's session and making the recording as well as the slides available to you through Cracks in the Ice. So today's speaker is Associate Professor Shalini Arunogiri. She is a clinical addiction psychiatrist. She's also the clinical director of the Victorian Statewide Centre for Addiction and Mental Health at Turning Point. Shalini is amazingly also the chair of the Royal Australian and New Zealand College of Psychiatrists and a board member for the International Society of Addiction Medicine and an NHMRC Emerging Leader Fellow at Monash University. She has over 50 peer-reviewed publications and over 14 million in research funding following completion of her PhD in methamphetamine psychosis. Shalini is also a passionate advocate for women in medicine and Hello, I think I just fell out and then just came back in. Sorry, everyone. Where did I get to, Shalini?
I was finishing the bio. The slide sharing is gone as well, so I think your slides.
Okay, that's all right. We can live without the slides. Sorry, everyone. It must be a Friday. So Shalini completed her PhD in methamphetamine and psychosis, and she's also a passionate advocate for women in medicine and research, and a mum to an energetic 6-year-old boy. So thank you for joining us to discuss methamphetamine use and mental health. I just wanted to note that we have previously had a webinar on psychosis, and that is available to watch on Cracks in the Ice. So I did ask Shalini to focus on some of the other mental health issues that can come with methamphetamine use. So please don't be too disappointed if she doesn't talk about psychosis. Thank you so much for joining us today, Shalini, and I'll hand over to you to present.
Thanks, Steph. I'm just going to go ahead and share my screen. So you're currently seeing my desktop. I'm going to share that, and hopefully you can see my presenting screen now. So just to start off, thank you so much to Steph and the Cracks in the Ice team for having me along to talk a bit about mental health and methamphetamine use. I'm joining the webinar from the Wurundjeri lands of the people of the Kulin Nation here in Melbourne, and just a pleasure to be able to kind of discuss a topic that's really continuing to be a real challenge, I think, for a lot of people across Australia in terms of managing mental health comorbidities that arise in the context of methamphetamine use. As Steph mentioned, today what we're going to be talking about is what we consider sort of high prevalence problems in relation to mental health, being depression, anxiety, and suicide, and also talking a little bit about ADHD as well in the context of methamphetamine use. I'll cover approaches to care, including harm reduction, treatment, and support. What we're not going to be talking about today is psychosis, and as Steph has mentioned, there is a really great Cracks in the Ice webinar on that by Professor Rebecca McKeaton, which you can access on the Cracks in the Ice website. There's also a previous two-part webinar on medication treatments for methamphetamine use disorder. So that's not in the context specifically of mental health comorbidity, but specifically around methamphetamine use disorder and methamphetamine dependence. So if you are looking for information and sort of pharmacological treatments for meth use, you'd be best to kind of check out that series of webinars on the Cracks and Now's website. So today I'll just start us off by talking a little bit about the sort of prevalence of methamphetamine use in Australia, and also the prevalence of mental health problems related to meth use. This press release and some data was just from a couple of months ago, and highlights, I suppose, that methamphetamine use is still a major issue in Australia. This study is specifically around wastewater monitoring data. And there are a range of kind of limitations and caveats that apply to wastewater monitoring data. But in comparison to, say, 25 other countries internationally that have similar wastewater monitoring programs, Australia has the highest rate of methamphetamine use in comparison to those other countries. And if you look at our prevalence data here in Australia, and this is largely based on the 2019 Drug Strategy Household Survey, the current wave of the 2022 survey is currently underway. So the latest data we've got from a couple of years ago, pre-pandemic, highlights that about 1 in 75 people report using meth in the last year. And about, in terms of the proportion of those people who use regularly, that's usually defined as about weekly or more. You're looking at a much smaller proportion of that group. If we then sort of think about mental health conditions in relation to meth use, there's a couple of snapshots from the National Drug Strategy Household Survey that highlight that both methamphetamine use is a major problem in non-metropolitan regions as well as in metropolitan regions. You can see here that the graph on the second part of the slide, where inner regional, outer regional, and remote and very remote regions are represented there, and have a really high prevalence across the waves of data collection from 2004 right up to 2019. It'll be interesting to see how this might have been affected across COVID and related lockdowns. I think there is some data clearly in Victoria and in New South Wales that suggests that there were some drops in methamphetamine use prevalence over that period of time. But so that next National Drug Strategy Household Survey information will be really helpful. In terms of mental health comorbidities, this slide pertains to sort of psychological distress specifically, and breaks down sort of low, moderate, and high levels of psychological distress. And you can see overall that if you look at everyone who uses substances and uses methamphetamine in any capacity, 3.6% of that group report experiencing very high psychological distress. But if you look at out of everyone who uses methamphetamines in the past 12 months, you've got a really high proportion, more than a third of people reporting a high level of psychological distress. And if we think about that group as well in terms of diagnoses of or treatment for mental illness, here again, we can kind of see that that is about a third of the group. So if you think about everyone who uses methamphetamine regularly, and again, reminding people that that's only a small proportion overall of people who might have used over the course of their lifetime or over the course of the last year, in that group of people, we're having really high rates of kind of psychological distress and mental illness. And in comparison to other drugs, this data is from the 2016 National Drug Strategy Household Survey. And you can see there in comparison to people who report using other drugs, including any illicit drug, or if they use cannabis, ecstasy, or cocaine, people who use methamphetamine have the highest rate of kind of self-reported diagnoses or treatment for mental illness. And this, I suppose, is why we're talking about this today, in recognition of the fact that this is a really major problem for people who use methamphetamine regularly. And it's a really common kind of presentation across mental health services, primary care services, and drug and alcohol treatment services. So switching back and wanting to talk a little bit about those conditions specifically, I'm introducing this section and the next sections with some interesting advertising material from a few decades ago, where there wasn't really an understanding yet of the risks in relation to amphetamine type substances and methamphetamine. So these ads pertain to benzodrine, which was a name for amphetamine sulfate, and raphamine phosphate. And hopefully you can kind of zoom in or see that on your screen, but both of those ads really are talking about how methamphetamine or amphetamine type substances in these cases can relieve psychogenic tiredness, that it has mood effects, that it revitalizes someone or causes sort of cheerfulness, optimism, a sense of well-being. And so this is unsurprising. It's probably unsurprising for anyone who uses amphetamines or has used amphetamines, because that acute effect is very much aligned with this sort of advertising and marketing material. It is really about a mood lift. It's about sort of dopaminergic effects largely that kind of hit that reward system and trigger that sort of sense of positivity, cheerfulness, elevation in mood, elation or euphoria. What we're talking about is that other side of the coin. So what happens when someone's using regularly and someone can develop a dependence or an addiction to the problem and then develop kind of subsequent mental health problems, including depression, anxiety, and suicidality. So we did a systematic review meta-analysis on this topic a number of years ago, and we were interested in mental health outcomes in relation to the use of methamphetamine and amphetamine type substances. And in that systematic review, we looked at a range of different mental health outcomes. Show you the sort of overview of the studies we looked at. And here we were interested in studies that were specifically measuring the use of amphetamines or methamphetamine, and also looking at that in relation to mental health outcomes, so that mental health outcomes had to be sort of measured in a validated way. And the specific outcomes we were interested in were psychosis, violence, suicidality, and depression and anxiety. This was a pretty exhaustive search, and we had a large team of people kind of working on this study over a long period of time. And we were particularly interested, I suppose, in trying to understand a couple of things. We were interested in sort of causation and being able to understand, for instance, were amphetamines or methamphetamine able to cause kind of these problems, whether or not there was a higher risk of being able to kind of develop these problems when you used amphetamine or methamphetamine regularly. And as you can see through that breakdown, the challenge with doing a review and a meta-analysis like this is that we were really limited by the number of studies that were longitudinal or prospective in nature. There were very few studies across the course of this review. I think out of memory, it's about 115 of the 149 studies that we got in the end were cross-sectional. So they were just a snapshot or observational in time. And so many people will understand with the limitation of cross-sectional studies that we're not able to know, was the meth use causing these problems, or these problems predating the use, or a variety of other things contributing to both meth use and these mental health outcomes. But the evidence being limited as it is, we're still able to kind of make some meaning of that information. And here today, we're talking specifically about depression, anxiety, and suicidality. So in relation to those results, what we found was that any use, we looked at both any use and use disorder. And if we looked at the studies that measured any use of amphetamines, that was associated with about a 1.6 times higher risk of depression. We also adjusted for a range of different confounders, such as demographics and other substance use and other premorbid factors. And you can see that the adjusted odds ratios are presented after those odds ratios. And so with depression, we had a 1.6 ratio, and then that dropped to 1.3. After adjustment. And for suicidality, this is a pretty staggering finding in the sense that there was a 4.4 times higher risk of suicidality in people who are using any use of amphetamines, and that dropped down to 1.7 after we adjusted for confounders. In terms of amphetamine use disorder specifically, that was still statistically significant and was associated with higher odds of 2.3 in this case. For anxiety, the challenge for us was that there weren't enough studies for the anxiety use outcomes. There was in fact no data available for any use kind of outcomes in relation to anxiety, and only 3 studies that had a use disorder in relation to anxiety, and they didn't find any significant associations. So that kind of limits what we're able to say in the space of anxiety and methamphetamine or amphetamine use in this type of sort of analysis approach. And it really kind of points to the need for kind of more research that specifically looks at anxiety outcomes. Anxiety outcomes include everything from sort of generalized anxiety disorders to phobias to PTSD, for instance. And it really highlights this really not enough research in that space. In terms of the results, this gives you a big sort of overview of what the results look like. Just drawing people's attention to the sort of fourth column on there that highlights that level of evidence. And so you can kind of see that this is the way, for instance, that we think about the studies that we draw the evidence from, and studies that have a higher level of evidence, for instance, randomized controlled trials or experimental evidence, were given kind of grade A level in this criteria. And you can see that really we don't have grade A level evidence for any of these outcomes. High level evidence in terms of cohorts or prospective, particularly cohorts that are sort of population based. You can see that depression and psychosis in relation to amphetamine use disorder has a higher level of evidence. But you can see that for anxiety, we really have very little to no evidence in this space. And this is a graphic representation with the use of forest plots, highlighting in the first category any use in relation to mental health outcomes. I've presented sort of the psychosis and violence information is available there as well, but drawing our attention to sort of the suicide and depression outcomes in the bottom half of that slide, and highlights, I guess, a range of different kind of outcomes across the board here. And you can see with depression, some of those studies have on that sort of where that line is crossed. Majority of those studies are higher than sort of 1 in terms of that ratio, but you can see that overall you're sitting in sort of that 1.6 category. In terms of use disorder, and so this amphetamine use disorder in relation to mental health outcomes, we can see there again at the bottom half of that slide that suicide and depression outcomes are still elevated, but suicide is statistically significant here. And I guess in relation to suicide specifically, what we know is that this is probably an under-recognized and under sort of measured phenomenon in people who use methamphetamine regularly. This study that was released in 2019 was looking at all Australian cases of methamphetamine-related deaths between 2009 to 2015. And out of all of those cases, they looked at, this was the National Coronial Information System, they looked at mortality rates, the characteristics and circumstances of death, and looked at blood toxicology, and had a total of sort of 300 cases over that period of time. 18% of those cases were methamphetamine-related deaths, and 1.6% of them were completed suicide. So that's a really high proportion, and 77% of that group were men, and the mean age there was 33. So these are young men. In terms of kind of looking at that group, a quarter of that group had previous attempts, previous suicide attempts. And these are previous attempts that would have been known to kind of health services, be that sort of acute health services or mental health services. And 12% of that group also had a history of psychosis. So it really kind of highlights, I guess, those opportunities for sort of intervention, those opportunities to kind of engage people in the treatment system where there have been potentially suicidality or psychosis or other symptoms that bring people to the light of kind of treatment services. And the capacity, I suppose, to be able to intervene and reduce that risk in future, because this is a significantly high risk. And in terms of, thinking about overall morbidity and mortality, we also know clearly that methamphetamine is related to a range of physical health problems that can cause a significant kind of risk, including death. And a lot of the mortality that's associated with methamphetamine are related to coronary disease or cardiovascular problems, including cardiomyopathy, stroke, or kidney and liver disease. So this is also part of that picture. We know that there's been overall a rapid increase in methamphetamine-related deaths, and most commonly that's accidental toxicity. And as I was saying before, suicide and accidents also comprise a significant proportion of deaths. So if we think about depression and anxiety specifically, I've talked to you a little bit about sort of the meta-analysis evidence that's kind of looking at all studies kind of conducted to date, and that was back in 2019, studies conducted up to that point. Currently, there's a range of newer research trying to look at this in a different way and look at sort of prospective data as well, trying to understand how depression and anxiety symptoms can develop, but also how they interrelate with how people engage with this treatment system, and how people might also be experiencing other life adversity, clearly, including sort of homelessness, social adversity, family violence, for instance. So a lot of the range of research is coming from a group based in Victoria in relation to the VMAX study, which is Australia's largest sort of methamphetamine cohort of people who smoke methamphetamine. And this is across but metropolitan and regional settings. So drawing people's attention to one of the papers from PhD candidate Zoe Duncan, who works as part of that team, and specifically looked at correlates of sort of anxiety and depression in that community cohort. And this was from the baseline interview with 725 people across a range of sites. That's the Bendigo site, which is the main site. And people completed sort of a range of questionnaires, and specific to depression and anxiety, completed questionnaires, including the PHQ-9 and the GAD-7. And with that group, they found that more than half of that cohort had moderate to severe anxiety or depression, which again is consistent with international data, but also highlights a really high morbidity and morbidity levels in this group. So if you can see there, the breakdown of both anxiety and depression scores. On that top row, you've got anxiety, and on the left, you've got kind of the depression breakdown. And in the shaded grey section is people who had both anxiety and depression symptoms. You can see that in this group, about 8% had moderate to severe anxiety only, and depression about 13%. But in terms of both groups, you've got the 37 or 38% there having both. So a total of all of those groups together in that moderate to severe category equals to about 60% of that group. We know that compared to the general population, these are significantly higher rates. So for instance, in the general population, if you've got in this group about 46% having moderate to severe anxiety, general population rates are about 10 to 13%, much lower. And then again, if you look at moderate to severe depression, the rates of depression overall in the general population are about 10% in comparison to this group where it's closer to 50%. So this is a group that's in the community. They're not treatment seeking. They're not necessarily in kind of your pointy end of sort of treatment services. And so it really highlights that this is the group that's carrying a lot of mental health problems and carrying a lot of distress as well. And in terms of kind of thinking about this study specifically, they also wanted to see whether there were any other predictors or any other factors correlated with anxiety and or depression. After adjusting for a whole range of different things, they found the three things that kind of still related to both anxiety or depression were self-reported poor health, and that includes sort of self-reported poor physical health, methamphetamine dependence specifically, so people who are using less or weren't using in a dependent fashion were less likely to have these problems, and employment status, so unemployment was highly correlated with both those problems. And that's probably unsurprising if we take a step back and think about how these factors kind of interrelate to contribute to someone's mental health. But I guess from a treatment perspective, and also from thinking about how we actually change treatment services to be more effective, these are things that could be modifiable. These are things that we can actually help intervene on to be able to help people navigate the space. In terms of gender differences, women were more likely to have a higher odds of moderate to severe anxiety compared to men, and this is consistent with the general population. There were no difference for depression between genders. Turning to another study around sort of depression as well, and the utility of kind of thinking about this study is also helping us understand what the difference might be between depression and anxiety symptoms, or depression here specifically, that might be substance-induced versus an independent sort of primary disorder. The reality is, I think, with all mental health comorbidity, it's really challenging to be able to tell cross-sectionally in a snapshot when someone's using regularly, whether that problem is related to the substance use or whether that problem is an independent disorder. And this study demonstrates that really well. It's a 2011 study that looked at a cross-sectional survey of about 400 people who are entering 41 different sort of specialized drug and alcohol treatment facilities in Sydney and in Brisbane. And so this group included sort of detox facilities, residential rehab, and counseling programs as well. And if you think about that whole group, they had an extensive sort of interview, and that included a diagnostic interview in relation to depression. That diagnostic interview gave this team a capacity to be able to comment on what was a primary major depression problem versus what's the substance-induced depression problem. And here they found the prevalence of sort of major depression in this group in that year leading up to the study was about 40%. Again, this is similar to what we've just talked about in that broader community group. But then a further 44% of this group also had symptoms that was more suggestive of that substance-induced profile rather than an independent disorder. So if you take the two together, a substance-induced depression or a major depression, you just think about the symptoms in and of themselves. We had 88% of that group who were entering treatment services that actually met criteria for having a depression. So that's huge. And also, if there are any clinicians in the audience, that's probably similar to what you probably see in your practice, in the sense that, almost universally everyone that we see has some level of sort of depressive symptoms. Particularly if we think of that sort of pointy end of people who are dependent or using in a dependent fashion regularly. In this study, just highlighting again that sort of difference in that symptom profile, the value in kind of thinking about this, and something for me as a psychiatrist, the value of kind of, reflecting on this, the differences between substance-induced versus major depression, is that even in a really systematic study such as this, where we've got a really kind of extensive interview process and a range of questionnaires, the majority of the time, we can't really tell the difference between those two disorders. And when you look at the symptoms, here they have kind of the symptom differences between the two types of groups. There really isn't much to tell between those two different groups. So you can see there those asterisks and the crosses kind of point to the symptoms that were different between the groups and that were statistically significant between the groups. And really only the kind of 2 or 3 things that we're looking at were people who had extended periods of sort of feeling sad or empty. So those persistent depressive symptoms for more than 2 weeks at a time. People who have that sort of major depressive syndrome are more likely to report that. And again, people who had suicidal ideation were more likely to fall in that major depression group rather than substance-induced group. But really the vast majority of kind of symptoms were not that dissimilar between the 2 groups. For this group as well, and in this study, I really encourage people to kind of go off and have a read of the study if you're interested in this space. But half of the participants in this group who had experienced kind of major depressive symptoms last year had taken antidepressants. And also about a third, about 27% of people who didn't have any symptoms had also taken antidepressants. So the use of antidepressants is really high in people who use methamphetamine. Often people are prescribed this sometimes by primary care or general practitioners. But I think what we're seeing here is that antidepressants in and of themselves aren't changing the symptom profile for most people when they're continuing to use. And that's a really common kind of problem, I think, in the sense of the antidepressants not being necessarily particularly effective in being able to change this profile in the context of kind of active use. In terms of other substance use, and that's also really relevant when we think about this, because I think the majority of kind of people we see, particularly in treatment settings, are using more than one thing. And for this group in this study specifically, most people in this group, about 79% had used cannabis, and mostly on a regular basis, so about 18 days out of the last month. And alcohol use was also not uncommon in this group. So about 74% of people in the study had reported alcohol use regularly. So about 21% of people were drinking at a daily level. So again, really high rates of kind of other substance use. And we know that other substances in and of themselves also contribute to that risk of sort of depression and or anxiety, particularly alcohol. So it's important that, I guess, when people are kind of coming into treatment services, that we see all of that as a whole and together. So those symptoms are occurring in the context of a whole range of other problems for someone. So I guess the take-home messages in relation to sort of depression and anxiety from a range of these studies highlight that these symptoms are really commonly occurring with methamphetamine use. In some cases, they might predate use. In many cases, they're concurrent with use. And the important thing there is for most people, they persist in sort of that early recovery. Haven't gone into too much of the data in terms of how long those symptoms can last for. And the evidence is a little bit patchy, because I think research in methamphetamine withdrawal in and of itself is quite limited. There aren't a lot of studies that kind of track people through recovery in relation to meth use. But what we do know is that those depressive and anxiety symptoms often persist for people past that acute withdrawal phase. They start to subside for many people in that 1 to 2 week mark. But for a lot of people, those depressive symptoms in particular, anhedonia in particular, that failure to sort of be able to get pleasure from daily activities or from social connections, those sort of symptoms can be really problematic, and they can hang around for kind of 6+ weeks, 6 to 8 weeks. And so it's important kind of having that frame, I guess, of reference in terms of, should we treat these problems or not? Can we tell the difference between sort of induced problems versus primary problems? And I think the data really suggests that we can't necessarily. And does it matter? Do we need to know whether which came first, and in order to be able to manage it effectively? And I'll argue in this case, and as with much of mental health comorbidity, it doesn't always matter whether we need to be able to tell what comes first in order to be able to offer kind of holistic, integrated, and useful support. In terms of this next section of the talk, changing tack a little bit and talking about methamphetamine use and ADHD, attention deficit hyperactivity disorder. And this is a complex space. I wanted to start off by, again, using an advertising material. And here, drawing reference to something that was published decades ago, that opened with the headline of "Soon we'll all be brilliant." I'm not sure if everyone can read it, so I'll read it out to you. This was highlighting that the effects of benzodrine, amphetamine sulfate here, a new drug which gives confidence and increases initiative and promptitude in making decisions, described in the British Medical Journal. Medical men, specifically men here, who have taken the drug have found it of value in such tasks as lecturing and examinations, states the article. It also helps to remove mental fatigue and aids in a convincing and fluent speech. The danger of addiction is stressed. So even at that time, they had a line about the danger of addiction, which is reassuring. But it highlights also those effects that even in the pharmaceutical version of this drug, when it was marketed, really pointed to kind of the capacity for methamphetamine to kind of help with kind of attention, concentration, value in sort of executive function and here in public speaking as well. So it really highlights that the medication, in the medication form, stimulant medications, which being the main form of treatment for ADHD, are really aligned with being able to promote those same effects. When we think about methamphetamine use and cognition, broadly speaking, and they'll highlight why this is such a complex area to kind of really get good answers in and straight answers in. These are a range of studies that have been conducted internationally, including a number by our group here in Melbourne. And to summate a whole range of literature in this space, what we do know is that there are a range of cognitive impairments that if cross-sectionally you go and measure them in someone who uses methamphetamine regularly, you'll find a range of problems. Those problems can include sort of executive function problems, verbal memory problems in particular, and difficulties with sort of decision-making or impulsivity in particular. If you look at that snapshot cross-sectionally, we also know that if we look at people kind of in that first 4 to 6 weeks after treatment, including sort of detox treatment, many of those symptoms can persist over that early recovery period of time. But as one of my colleagues, senior neuropsychologist James Gooden, pointed out recently, and this was in a clinical audit that we did in our clinic at Turning Point, it may not be the methamphetamine causing all of these problems. Many of the studies in this area don't necessarily kind of draw out what happened before someone started using methamphetamine. We don't have good literature on what someone's kind of cognition and cognitive function was prior to the use of drugs, because those studies are very challenging to kind of do and need data on being able to follow up people over a long period of time. So if you think about that, in this space, we know that cognition is affected, that it's impaired during regular use. It's also impaired during withdrawal, and it gradually improves, but that period of time might be quite long, and that some types of thinking and memory are particularly affected. That includes social cognition, a particular area that of my interest, and that's particularly important, I think, for people who use methamphetamine, because as anyone who's kind of tried to navigate recovery knows, that the capacity to be able to kind of have social connection, to be able to find new connections in a new sort of social circle is critical in that period of recovery. And social cognition is really about being able to kind of read other people, being able to kind of have conversations and have that interpersonal connection. And that can be really impaired when you're using methamphetamine regularly, and it can take a long period of time for that to become more effective again. But as we've pointed out, is it the methamphetamine use specifically? We're not really sure. Could it be current mental health comorbidities that happen at the same time? Could also be pre-morbid or prior to use comorbidities. And also that whole layer of sort of, vulnerability or disadvantage, layers of trauma that might happen prior to use even, and background sort of education status as well. So all of these things contribute to how we measure cognition and what we actually see. Regardless, I suppose when we look at sort of people who enter treatment, those problems are often present at a treatment entry. As I mentioned before, they also often persist for a period of time. And this context is kind of really important when we start to think about how we identify, assess, and treat potential ADHD in this space. So if we think about how that affects how we assess for and diagnose ADHD, this is a relatively sort of topical and somewhat controversial area, the treatment of sort of ADHD and concurrent substance use for a range of reasons that I'll go into, but specific to methamphetamine use. What we do know, and that little kind of advert that I opened with really hit the nail on the head in relation to this, we know that stimulant treatment improves cognition in everyone. Regardless of whether you have ADHD or not, that stimulants improve concentration, attention, and a range of executive functions up to a point. That dosing profile is important, and if you have too much of it, most people's cognition gets to a peak and then really doesn't get improved any further. But if everyone was in stimulants, maybe someday we'll all be brilliant. That's a point of discussion. But I guess in terms of thinking about improvement in cognition in and of itself, that's not necessarily the most effective means for us to be able to track whether or not the underlying profile is something consistent with ADHD, because stimulants are likely to improve the profile for everyone. This is particularly the case for people who have methamphetamine use disorder, because as we've pointed out, in that active use phase, and then in that early recovery phase where that extended withdrawal syndrome occurs, we know that there are a range of cognitive impairments, and a lot of those cognitive impairments look very similar to a profile for ADHD in and of itself. So if we look at kind of cognitive studies in adult populations of people who have ADHD, they're not dissimilar to adult populations of people in methamphetamine withdrawal or recovery when those individuals don't have ADHD. So whether or not there's underlying ADHD, we know that stimulant medications in and of themselves will ameliorate these symptoms. So when we assess ADHD, the question arises as to when we should assess it. Should we assess it when someone's actively using? Should we assess it after a period of prolonged, maybe probably 2 months plus if we want to do that, prolonged abstinence, to be able to kind of conclusively tell whether the ADHD is part of the syndrome? And as I've discussed before as well in relation to depression and anxiety, there's that third question of, does it matter? So do we need to know whether there's underlying ADHD in and of itself? There are a range of different kind of conversations and questions around that. And it also depends, I guess, on your perspective as to whether you're a prescriber, whether you're a sole prescriber, for instance, a private practitioner, for instance, who might be taking on a level of risk with prescribing for an indication where it's not clear whether or not that disorder is there. So, I mean, clearly a complex space. But I think then that next step is also about being able to treat ADHD with the presence of sort of objective and specific markers of improvement and benefit, especially functional markers. So beyond that sort of neuropsychological testing or cognitive function alone, as I said, that may not necessarily tell you whether ADHD is an underlying problem. Because here we really want to be able to see that the medication is helping the individual in a whole range of ways, right? So we want to be able to tell whether it's helping with work or engagement and activity, a social connection in particular, because all of these factors are also going to facilitate recovery from meth use disorder. So it's important that, when we work with people, that we're able to kind of identify what those markers are, what those functional improvements are that we're looking for. So as I mentioned, this is a complex space and still a controversial space for a range of reasons. I encourage people to kind of go off and read about this in a little bit more depth. I was involved with sort of 5 colleagues in writing a couple of papers here. The 5 of us probably have not distinctly different views in this space, but we wanted to kind of really point to those 2 poles of this argument in these debate pieces. Being able to talk about the assessment of attention deficit hyperactivity disorder, so in the context of substance use specifically, so not necessarily in the context of methamphetamine specifically, but broadly in substance use disorder, whether or not screening, identification, and assessment was necessary, and then whether we need to actually think about what the treatment approaches look like before we decide whether we want to assess or identify this. So that's 2 ends of that argument. I'll take you through some of the key points there. So broadly speaking, the things we can all agree on, and I think a lot of this is proven through very well conducted, very robust and rigorous kind of cohort studies over kind of decades of time, largely in Northern Europe. Here we know that children with ADHD have much higher odds of developing a substance use disorder later in life. We know that ADHD doubles that risk, and that approximately 1 in 4 people who have a substance use disorder have co-occurring ADHD. This is all substance use disorders, not specifically meth use. In terms of ADHD, we know that once it's there, it often complicates clinical profile and treatment. Studies have suggested that ADHD is associated with increased sort of complexity of that substance use profile and that longer duration of sort of treatment, that it might kind of promote a challenge for sort of treatment efficaciousness and retention. And if you think about the fact that a lot of treatments for substance use disorders are very cognitively based, for instance, cognitive behavior therapy is kind of that gold standard approach to treatment, we know that this might be a challenge for people who have ADHD or untreated ADHD. Also, ADHD increases that overall likelihood of criminal justice contact, reduced quality of life, suicidal behavior, and premature mortality. And so these are a whole range of different outcomes based on the premise of untreated ADHD in that space. But then if we think about the other side of the coin, these are a range of questions that still have some controversy. They're not things that everyone agrees upon in this space. So a question around diagnosis of ADHD in the context of active substance use disorder, especially methamphetamine use disorder. Can it be reliably done? Can it be efficaciously done with the existing kind of tools and instruments? So this is a really divided space. There are a range of studies that suggest that it can be done effectively. And when I say active substance use disorder, there's also a range of literature in how they define that. So here, some studies and some clinicians may be identifying kind of ADHD in the context of kind of active, current, regular substance use versus that other period of kind of abstinence and early recovery. Could be within the first month, could be longer than that as well. So identification in the context of sort of 6 months. I think conclusively it becomes easier with that longer period of abstinence because there's less kind of confounders in relation to withdrawal. But there are some, essentially some authors that suggest that it is possible and some that suggest it isn't possible or isn't possible with some of the subjective kind of instruments that we have, such as the SRIs, for instance. Then the next point of contention is whether standard ADHD treatment using stimulant medication, whether that's as effective in the context of active substance use disorder. And the reality is we just don't have enough evidence in this space, particularly for stimulant use disorders. We don't have enough evidence to kind of suggest what are the doses that people might need. The initial evidence really suggests that people might have a higher tolerance for stimulants overall. So here that suggests that if you were going to prescribe that, you need to first of all prescribe stimulant medication rather than the non-stimulant medication to get an effect. Medications such as atomoxetine, for instance, or other medications that are non-stimulant type ADHD medications may not be as effective anyway. And also some of the existing studies have really high dropouts or more subjective outcomes where it's a little bit hard to see whether recovery from the substance use disorder in itself is kind of promoting improved function, regardless of whether ADHD treatment is effective or not. So it's still a controversial space. And then in terms of pharmacological treatment, is that associated with risk in the context of active substance use disorder? And a lot of discussion, I suppose, focuses on just this point, but it is one point in the context of a range of other points here. Risks may be in relation to sort of misuse or diversion. To some extent, these risks can be mitigated by prescribers in the sense of being able to prescribe with some contracts, for instance, with limited dispensing arrangements to limit that risk of misuse and diversion or diversion into sort of an illicit market. And, clearly promoted by being able to have sort of good rapport with your patient as well. In terms of other risks, there are also significant risks and probably under-recognized or under-reported risks in relation to sort of both toxicity and to some extent psychosis. When there are studies of sort of the use of stimulant medications in people who have ADHD without a substance use disorder, there is a small risk of sort of psychosis or worsening of, say, axis 1 psychotic disorders. That's a very small risk, almost negligible, but fairly small. But then if we think about people who have a substance use disorder or an active substance use disorder, that risk is higher. And it's particularly higher if people are using more than the prescribed amount of ADHD stimulant medications. So it's a risk that does need to be acknowledged and thought about when someone's kind of undertaking a prescribing arrangement. So quickly moving through some of the other kind of challenges and complexities in this space. We've already talked about with methamphetamine use disorder, there's a whole range of other mental health problems that can co-occur in the space, and that overlap between symptoms, such as, symptoms that might arise from childhood adversity, from relational trauma that might arise in childhood, from kind of ongoing traumatic events that might happen later in adulthood as well. All of these things kind of undermine kind of being able to achieve educationally as a child. And then in adulthood, being able to kind of attain or achieve other things later in life as well. And so that overlap between symptoms can make it really challenging. I would argue sort of virtually impossible, and particularly in current sort of public service environments, and even in private, very hard to access these types of assessments. In public services in particular, what undermines this capacity to be able to do this work well is that lack of continuity of care, both in drug and alcohol particularly, but also to some extent mental health services. We have very sort of episodic, very brief periods of care, so we don't get to work with people long enough to be able to see whether this is a problem for them, to be able to see whether if we tried medications, would they be helpful or unhelpful. We just don't have enough time to be able to do that effectively, and it would be great if we did. I think the other side of that coin is also the lack of workforce capacity. There are very few funded kind of positions where I work in Victoria. I've got less than 20 sort of EFT of psychiatry time across the state in public services. And so that really means that this is a very scarce resource, and broadly across general kind of workforce across AOD and mental health services, there's very limited training and knowledge of ADHD as a whole, let alone ADHD and concurrent substance use, and a lack of resourcing in this space. So I think where a lot of kind of grassroots advocacy is happening at the moment, and community advocacy is really helpful, is being able to kind of highlight the need for more sort of resourcing, more research, but also more training in the space to be able to kind of upskill clinicians to be able to work more effectively. In the context of that, in the context of a really under-resourced environment, the question arises as to whether we should be screening for this more effectively, whether we should be universally screening. And as I pointed out, those two papers highlight why to screen and why not to screen. The positive kind of argument for this is really to be able to identify and quantify that burden. We argued in that first paper that if we don't kind of screen, if we don't necessarily know the extent of this problem, we're unlikely to be able to get enough resources to manage it well. The other side of that coin, they're probably likely to have a lot of what we call false positives, but basically a whole range of other problems that are also going to be contributing to kind of similar picture. And I'd probably say that many of these other problems are also poorly treated within the sort of public system at the moment. So it highlights also that risk of being able to screen in the current context where people can't necessarily access treatment or can't access effective longer term care. That also is a major risk and can be quite harmful for people. So this is where we kind of left things. So as a result, I guess, in the current context, what we know is that clinicians are often reluctant to undertake assessment because they're unable to kind of provide that realistic and accessible treatment recommendation. It can place clinicians in a sort of role of conflict where we're asked to identify the presence of condition where they may not be able to manage that effectively. And that's a challenge. It's obviously a major challenge for people who are trying to access treatment and effective care. If clinicians are kind of caught in this context as well. So that's the argument sort of raised by Jesse Young and Mark Belgrove and myself. So if we move quickly on to sort of treatment approaches, and we'll have a little bit of time at the end to kind of take questions. I guess anyone's familiar with sort of the public treatment system for mental health services more broadly, and definitely for sort of integrated care, is that often the onus is kind of on the individual to be able to access treatment, to be able to kind of be retained in treatment. But services can be really hard to access, and we have to kind of start thinking about how we reorientate the service framework to kind of focus on making services easier to access, rather than saying that people need to kind of be able to kind of continually call, continually try, have to be motivated enough to be able to access treatment. In terms of treating mental health comorbidity in this space, in terms of an approach, kind of assessment and treatment, we know that depression and anxiety symptoms are really common in both active use and recovery. There are no good evidence in terms of RCTs or other types of studies for which combination of medication approaches, for instance, or psychological approaches works best, that works better than any other. But standard approaches for depression and anxiety are likely to be effective if they're integrated with that treatment for meth use and with harm reduction approaches in this space. So if you actually treat both disorders, that's likely to be clearly more effective than if you only treat the depression and anxiety, for instance, with an antidepressant, without clearly intervening with the meth use as well. Individualized and holistic treatment is likely to be more effective, again, than the medication-only approach. And I've highlighted some really core principles here that also apply to core principles for depression and anxiety treatment. Focusing on sort of that sleep, diet, and exercise. They've got on the right sort of Maslow's hierarchy there in terms of capacity to really kind of target those bottom pillars of what's going to really help someone start to feel better before they kind of engage in sort of formal psychotherapies, etc. Social connection and peer support are critical, and will be able to kind of improve depressive and anxiety symptoms in and of themselves. And having that trauma-informed kind of framework through this whole process is also really important because we know about the burden of trauma in the space. Just touching briefly on sleep specifically, probably not enough time to kind of go through this in detail, but we know that sleep can be really disordered in people who use methamphetamine or stimulants regularly. We also know that methamphetamine has a direct effect on sleep cycle, regardless of whether, for instance, someone is using in a sort of a binge fashion and goes without sleep. We also know that the drug specifically affects sort of dopaminergic systems that regulate sleep. So that includes, to some extent, the circadian system, but also the ultradian sort of rhythm system. And so if you're interested, really encourage you to kind of go off and read about that. But what we're sort of starting to think about is what other treatments can be effective in this space to promote sleep and also protect against methamphetamine-related toxicity that affects the sleep system. So that might include sort of light therapy and a whole range of different types of light therapy. Also includes medications such as melatonin or agomelatine, which is an antidepressant that works on that same system. And melatonin can help the dopamine system in and of itself, and it also regulates sleep. In terms of psychological treatment approaches, we know that there's a range of them, and there's also good evidence for a range of treatment approaches that specifically work for depression and anxiety and meth use disorder in an integrated fashion. I've just touched on a couple there that include even brief treatment approaches that involve CBT can improve depressive symptoms, and a growing kind of range of evidence for mindfulness-based relapse prevention in the space as well. And then in terms of medications, as I've mentioned, I haven't talked too much about medications that specifically work for meth use disorder, but more recently, there have been a number of trials of medications that are antidepressants that work for depression and anxiety, and also appear to work for meth use disorder specifically. So these are really exciting, kind of newer wave of research that looks at sort of mirtazapine specifically, an antidepressant for methamphetamine use disorder, and improves both sleep and depressive symptoms in people with meth use disorder. And here, an article that looked at bupropion and naltrexone, and here the naltrexone in that study specifically was an extended release injection version. But here you can see that that improved methamphetamine use and also an improvement in, to some extent, depressive symptoms. Pointing out too that not everybody might be ready necessarily to quit using or to look at an abstinence sort of based framework. So the importance of also looking at harm reduction in this space, because there's a whole lot of things that people can do to protect themselves from developing sort of sleep-related problems, depressive symptoms, and anxiety problems in relation to their meth use. And just pointing out a whole range of information exists out there, including sort of this range from Queensland's Insight group that includes some cards that clinicians can kind of download and use with clients to promote harm reduction in the space. In terms of treatment guidelines, a shout out to sort of the Matilda Centre's comorbidity guidelines and our own method treatment guidelines at Turning Point, both of which have specific sections on depression, anxiety, and psychosis management in this space. And also to touch on a couple of clinical trials, both of which are looking to some extent on substance use meth use in relation to mental health symptoms. The Ready to Change methamphetamine trial is still recruiting. It's a telephone-based trial accessible to anyone who uses methamphetamine nationally across the country. You can go to our website to learn a bit more about that. And that's a 6-session psychological treatment that's over the phone. And the TINA trial, which I'm a part of, will be recruiting very soon, probably in the next kind of 3 to 4 months. So watch out for a trial site near you, and we're going to build on that mirtazapine evidence that you saw before with the trial specifically using mirtazapine for meth use. Just recognizing also the impact of kind of methamphetamine use disorders on people who can be around the affected individual as well. And really highlighting, I guess we've talked a lot about sort of depression and anxiety and people who use methamphetamine, but that can also be part of the picture for people around that individual. Highlighting a couple of really important and useful resources to support kind of family members and carers, including the resources from the Cracks in the Ice team, as well as us in Turning Point with our breakthrough program. And that's my final slide. So just by way of finishing, just wanted to acknowledge kind of the work that's already gone into this space and the courage of kind of other people and sharing their stories that contribute to kind of both the evidence that we build in this space, but also the evidence for kind of change in our treatment systems. Encourage people to go off and read about Rethink Addiction if you don't know about it already, and to share a story on our website. And that's me done. I'll finish up there. I'm going to take questions.
Great. Thank you so much, Shalini. That was really interesting to see so much overlap between methamphetamine use and mental health and how they often co-occur together, but it's difficult to tell which one comes first. If today's presentation has raised any concerns for anyone, there are a number of support services listed on Cracks in the Ice under Get Support Now, or you can call Lifeline on 13 11 14. We do have a few minutes for questions, and they have been coming in fast. So first up, do you know if there's any particular data around regional or rural areas, Shalini?
Yeah, so the best data I can suggest in regional and rural areas in relation to kind of, I guess, there's methamphetamine use prevalence, and then there's mental health comorbidity. So the prevalence data, probably the next wave of sort of the National Drug Strategy Household Surveys are saying that's currently underway this year. So probably next year we'll have that data, and that will point to kind of prevalence differences, particularly now post-pandemic. But in terms of mental health comorbidity, probably the best evidence comes from that VMAX study that I mentioned before, which really highlights, rural and non-metropolitan regions specifically, because they have a fieldwork team that go out and do these interviews across the state, including in rural regional settings. So, encourage people to go off and have a look at the VMAX website to look at the studies coming out of there.
Yeah, great. Thank you for those suggestions. There was a health worker who was wondering if there are any specific issues that they should consider or educate their clients about considering the use of antidepressant medication and continued use of methamphetamine.
Yeah, look, I think in terms of antidepressants, they're really widely prescribed, and so lots of people who use methamphetamine might be prescribed them. There's no specific evidence that I'm aware of that points to one antidepressant being more effective than any others. Of metazapine and bupropion both being used as treatments for methamphetamine use disorder. So in that space, they may be more effective in the sense that they might help with both the meth use and the depression. I guess some of these medications, metazapine included, really help with kind of sleep promotion, for instance, or sleep as a problem. And so for people who use regularly, that can be really helpful as well as a sort of off side effect. But I think in terms of kind of depression and anxiety, I think it's important to also kind of focus on kind of the whole range of other problems that can arise with meth use, and it might not just be the medication alone that's going to be helpful. It's going to be a range of different approaches.
Yeah, okay, great. Lots to keep in mind there. We also have a question about, do you think we have enough evidence to suggest that a neurodiverse inclusive approach to AOD would benefit treatment outcomes?
So I might change the question a little bit. I think, do we think that it might? And I think we definitely think that it might, but we don't have enough evidence. And I think, it kind of points to the fact that this is definitely an area that needs more research in terms of being able to understand, first of all, just even the prevalence alone, but also how that kind of affects the usual treatment approaches that we offer, how we should, actually be thinking about tailoring or changing treatment approaches for people who might be presenting with a whole range of different neurodiversity.
Right, yeah. And we also just have a question around trauma. You mentioned having trauma-informed approaches, and I wondered if you could talk a little bit more about that, as we've had a question around, depression, anxiety, and suicidality can be trauma-related, and perhaps that methamphetamine use is self-medication for the trauma.
100%. Completely agree. And I think that's the challenge with the types of studies that have been done in the space to date as well, is that we just don't have the capacity to be able to kind of look at this literature and be able to understand what's sitting behind all of these problems. Trauma is not always measured in research, and PTSD and trauma symptoms are not always measured, because I think it's often very hard to ask these questions in the context of research interviews, and sometimes that isn't routinely measured. And I think I myself am sort of doing a fellowship in meth use and trauma, specifically around this, a research fellowship, because I think if we don't ask, we don't know. And the reality is, if we don't sort of think about trauma, if we don't document it, if we don't measure it, we then don't necessarily have approaches that are going to address it effectively. But I think in terms of trauma informed care, that's certainly an approach that has been adopted across AOD and mental health services. that really kind of promotes the capacity to be able to kind of recognize that trauma can sit behind a whole range of these presenting symptoms, these presenting problems. Sort of work in a trauma-informed way really means that we need to kind of take that into account. We need to kind of think about how the treatments we're offering are sensitive to that approach. And also when people kind of are ready to work on some of these traumas that we have, capacity to be able to offer the treatment appropriately for that.
Yeah, okay, great. So we've also got another question about, from that family perspective you mentioned, they're often quite affected. Where can family get help for their veterans' use of substances? And is there any sort of specialised help out there for that population?
Yeah, I'd suggest people kind of go back to sort of open arms, so the national kind of veteran support services for veteran-specific available care. I think the range of kind of drug and alcohol supports that are operated by Veterans Affairs, but I think that also the family kind of services that operate within kind of open arms are also really, really helpful.
Yeah, okay, great. And we'll just finish up with one last question. Apologies to anyone who didn't get their question answered. There's quite a lot of them.
I'm happy to kind of take those offline as well. Yeah.
Okay, great, Shalini. There's a question about, are there any studies about meth exposure in utero and then children having ADHD later in life?
That's a great question. To my knowledge, there are no studies, and I appreciate it's probably quite hard to do. I think in terms of just generally substance use in utero and then measuring kind of childhood outcomes in offspring, very few studies even do that, let alone methamphetamine use specifically in relation to ADHD. So it's definitely an area of kind of growing research, and I'm aware that there's some sort of more newer sort of cohort studies as well trying to look at that, but really challenging area to work in.
Yeah. I guess it's a little bit like you spoke. It's hard to tell if the anxiety or depression started before the methamphetamine use or whether the methamphetamine use led to the anxiety and depression.
Exactly. Yep.
So thank you so much for Shalini. That was an excellent presentation, and lots of people have already written in to say thank you and how wonderful they found it all. Apologies again to anyone who didn't get their question answered. You're very welcome to get in touch with us via email, and we can respond to any questions or queries as soon as possible. We will be holding more webinars and putting new resources on Cracks in the Ice throughout the year. So I would encourage you to subscribe to our mailing list at cracksintheice.org.au to receive future updates. So thank you again, Shalini, and thank you to everyone who joined us today. And I hope you all have a lovely rest of the day. Thank you.